if I am able to do that. Yes. Uh, of course, the session of today is one of three that we are developing together with MCI. It's been a huge effort, as I said before, led by the University of Newcastle, Australia, and the Value in Health Economics and Policy group that has culminated in the publication of a special issue which is now available online, that really looks at the global response to COVID, both in terms of policy and technology. Obviously, we have covered, as I said before, 28 countries, examining the heterogeneity in the response. Obviously, that will be reflected in the panel, also other aspects, including the juridical and legal aspects that of course have been impacted as well. As countries, in particular, we have a paper that looks at these aspects, in particular with a focus on Australia. But Bin Lee, who's here with us today, will perhaps touch upon those issues as he's part of our wonderful panel. So we have, of course, a lot of collaborators and a lot of institutions that collaborated to this effort. And in let's say, in the effort to make access easy to this information, I will also provide this slide later on so that you can access, of course, all the papers online and download them for your enjoyment and learning. And of course, here are also the links to our Twitter and LinkedIn and so on, if you want to, of course, engage with us as we plan to continue monitoring this space. So now I introduce, first of all, the two speakers of today. Associate Professor Duan Lee, who is a colleague at the University of Newcastle and a member of VheP. I would say that he has been a great contributor as a guest editor in the journal called Health Policy and Technology, published by Elsevier. Of course, his area is finance, and we are working on many projects together. And he will present a number of ideas, really, that were covered in a special issue, and provide you an overview. And also insights on the impact of policy and technology on various aspects of society. Then the second presentation will be done by Dr. Naomi Moy, who is a research fellow at the University of Bologna. She has been also a guest editor in the special issue, and she will present actually a framework that is hopefully very useful for policy makers to think in terms of pandemics in the future, and clearly also this one, given that most countries are going in the so-called second wave. So without further ado, I introduce you to Associate Professor Duan Lee. Duan, floor is yours.
Right. Thank you very much, Francesco. First of all, good morning, good evening, wherever you are. Thank you for this opportunity to present in this webinar. Francesco, if I could, take over, I'll try to share my screen. And there we go. I hope that my screen is being shared. So as Francesco mentioned, what I'll be talking about, I think I have around 15-20 minutes, will be how, what were the things that multiple different governments were doing in terms of trying to set up a health policy and technology response during a specific pandemic, and why this is a special event that is very useful for us to assess how policy and technology responses were built up, and also what are the things that were being done to date. And then I'll expand on to why the special issue was trying to answer some of the issues that we will go through together. And finally, I'll talk about a specific case or specific technology, which I think is worth mentioning and discussing, because it would have a long-term, I think, contribution to how the global fight with the COVID-19 pandemic goes on in the next few months, right? So obviously, when a certain health crisis happens, then it's the obligation for a government and for institutions and academics like us, and also policymakers and people who are on the field, to try to set up new policy and new action plans. Now, when you're doing that, you always have to document the inputs and outputs. I'll discuss what inputs and outputs a bit further. But when a new policy is being set, it's obviously there's going to be the best response to the worst. The best will be if you can find a policy that can solve the issue right away. We call that an optimal. That's the best. If you can't do that, then the next best thing that you could do is start a policy. And then if it doesn't work out, revise it or turn to a different policy, learn from others, thereby you do a trial and an error. The worst will be to never learn from the past or from others. And these days, what's happening is that a lot of countries are electing to go through a trial and error phase because there were a lot of experience going on throughout the globe. Now, when I say there's an input and output, the input is the actual policy or the actions that the policymakers or the governments take. The outcomes could quite be different. The outcome for a pandemic was initially to save lives, right? But these days, when the second wave is coming, it's still to save lives, but then there's another item that is popping up, which is you need to sustain the economy. So the output or the target that you're trying to achieve from the policy slightly moves depending on what kind of situation you are. That's why these days, or even for the last few months, you've been seeing that a lot of governments are not only trying to implement health-related policies, but also trying to use stimulus packages or sort of physical sort of input to the economy to sustain the economy itself, right? So in the early stages this year, we were talking about a lot of things, and the main focus was obviously to save lives. So we were talking about herd immunization, and in the Scandinavian area, are we going to lock down the economy, lock down the whole, movement of people, thereby we try to control and eliminate the virus being spread out. So the early stages of the pandemic, it was more or less to try to come up with direct health policies to try to control and eliminate. Then as the lockdown period were going along and it was going further than we thought, and we were seeing that the businesses could potentially suffer. We were seeing that people with low income might have other alternative issues, which is due to low income than the other areas that we didn't think, sort of mental health, sort of just social well-being could be affected. The aim slightly changes to also include economic impact. But these days it's also changed a bit more, because you can see that yesterday, I think WHO announced that yesterday was the worst day for this year. We had around 440,000 confirmed cases worldwide. Thereby, it's not just the second wave itself is having an impact. And thereby in European countries and like in other countries, like still in Australia, in a specific state, Victoria, you could see that there is a lockdown period. And there's some people are having gatherings in the street, talking about anti-lockdown, and it's more about moving to discussion to, do we need to limit freedom of movement, and what kind of long-term health implications does it have? What kind of mental well-being can we support? And also in some countries, some countries are actually talking about, oh, do we need to really have this amount of private information being protected if we can actually swap it over with freedom of movement? So instead of going out to a full lockdown, if we can sacrifice a little bit of our private information and have less of a lockdown and have more freedom of movement, would that be a better policy or not? So there's debates are actually moving into several different directions. So you would see that there's more that will be happening. Thereby, it's very crucial at this point to actually document what other countries have been doing and which were successful and what are the conditions, so that some countries can mimic. In some cases, it may be by state level or federal level. There must be some discussion there. So why is COVID important? I'll slightly discuss about this. Innovation always happens when there's a disruptive shock, right? And innovation has two different streams. You have innovation that is evolutionary or revolutionary, which is sort of enhancing the previous innovations into a new level. but then you have this type of destructive or disruptive innovation, which actually is trying to take over the previous existing market. Now, this is a very business terminology, but when these kind of innovations happens, if it's isolated location, then it's hard for this innovation to spread around different locations. But COVID pandemic is sort of unique in the way that it's a worldwide pandemic. Multiple countries, almost every country around the world has been impacted, but it has been impacted in a very short time frame. So the impact and the response were all simultaneously happening together. The responses might have been different, but they were happening in a very short time frame. And the ultimate goal in the first stage were all set as the same: try to save as much lives as we can. So this is a very unique natural experiment where you have multiple responses being developed in different locations with the same goal, and thereby we can easily compare them without worrying about different time or different time zone, different time in the sense that it's not a response 10 years ago versus a response this year, right? So countries now are very eager to try to adopt successful method. You can see that news outlets such as Wall Street Journal is covering some successful technologies happening in the East Asian countries or even other places. There's commonly a lot of discussion coming out from very reputable news outlets about how we can learn from others and how the trial and error path should be taken, right? So just to clarify, this is just to talk about why the COVID-19 is a very unique case to look at. So what's happening to date? Well, because of the multiple responses and the difference, and even if it's the same response, the severity of the response or the degree of response by each country was quite different. So there has been some effort in the sense that the OECD or IMF or like the WHO, then you also have academics who are trying to track and record what the governments, whether it's again federal or whether it's local or regions, whether it's European region or whether it's other sort of related countries, they are trying to document what's happening. So OECD has done a good job in the sense that they have tried to measure it in two different categories from start. They not only looked at the health side, but they also are obviously a collection of countries talking about the economic growth for developing countries. Thereby, they are looking at the economic stability and how the healthcare system or how does the stimulus or the budget can address business, jobs, education, and try to stabilize the financial market itself. So I'll quickly show what the OECD has done. So this is an example of what OECD has done. For every country in the OECD, they have looked at the health response. This is just the capture of what they have done. So you can see that the 1, 2, 3, 4, 5, 6, 7, 8, 9, around 9 different categorization. And they were just doing a tick the box kind of practice. Did a country have any response or any policy implemented since the pandemic started to date that has ticked any of these categories? Right. So they're just tracking the record. They also, every 3 months, so every quarterly basis, they announce the economic outlook for each country. And you can see that this is just the top 5, 6 countries, and majority of them are growing other than Korea, United States, and Australia. Now, I'll be touching on Korea a bit further again, but Korea is quite unique because it's one of the countries that was really highlighted as having an issue in the early stage of the pandemic, but they have addressed it by implementing very aggressive, and some say it's intrusive technology. And they are expecting the economic growth to be at minus 1% for this year. That is much, much better than the other countries. The OECD G20 or the world is 4.5% decline in GDP growth. The European region is around 9.7%. Worldwide, it's going to be approximately 10.5 for all countries. If it's not just for OECD, OECD is 4.5, but if you go to all countries, then it's going to be expected to be around minus 10%. So definitely Korea has been able to achieve a very minimal impact on the economic growth, but also currently is maintaining, I think, the total number of confirmed cases around 26,000 to date. So around 100 people each day. Right, what else has been done? That's OECD. Oxford also started something very early in the pandemic where they were really trying to document what's happening in every country. They came up with the stringency and policy documentation, and they created an index out of it. So they are assessing the riskiness of each economy by looking at what kind of stringent measures have been put in. I think they look at health, economics, and then they also look at other areas, but it's by the School of Government. And they created an index, which is quite nice and fancy, which is something like this. So their total documentation they have comes up to a certain point, and that point is an indication of how dangerous it is to open the economy and give people full freedom of movement. And the darker the color is, it's very risky, saying that they are suggesting it's likely that doing a full lockdown is the most optimal policy itself. And they do it by country and they do it by time. So this is a nice way where the policymakers can actually address and look at their current period, or even researchers or people who are interested look at a certain country's current position and see whether the policy in which area should be more stringent or should be actually relaxed itself. Now, one of the other approaches that has been done is the working paper that Francesco has mentioned. It's a working paper by Moy et al. And they do a similar approach to OECD or Oxford, but they actually try to combine them and get the benefits of both approaches and do a hybrid model. And what they're essentially doing is also documenting and categorizing, and that I think is quite important, categorizing the policy and technology interventions. I think they use 4 different categories, and more of it will be discussed in the next presentation because Naomi Moy will be presenting it, Dr. Naomi Moy. But what they really do well is they put a focus on the health and technology part, because the rest of the 2 examples that I gave you do something about health, but don't look at the degree or the aggressiveness of the policy in the health and technology category. Technology category is also quite, it's non-existent in the OECD and the Oxford example, which obviously technology has become a really important aspect these days. And I'll come back to that, why that's important. Right, so then I'll go to what else has been done. Well, the previous 5 minutes I've been talking about is the methodology. How are you going to document? Now, what has happened after that? The special issue that Francesco, me, Jonathan, and Naomi have been working on was initially started around in April. So we've been looking at this for the last 5-6 months, and we use the Moy et al. Framework to try to document what's happening around the world. So the special issue is in press. It will be out in a few weeks' time. And what we do is, as Francesco mentioned, we cover 28 countries. We initially started with just 12 in April, but the ranking of the countries in terms of how many new patients were popping up was changing so dramatically. By the end of August, we had to invite more people from different countries, thereby 80 different academics have been contributing to this special issue. Not just countries, we also look at 4 specific topics where Dr. Binley would also be able to discuss about the impact on the judicial system or other topics. The 3 other topics were also included. So if you were interested, obviously it's a good place to check what's happening. There are other papers, like for example, I came across a paper today, which was published in September, I think 25th in the Lancet, which is also a very reputable journal, but they were only looking at 6 countries, right? This special issue has, I think to date, the best coverage of developing, and different continents. So if you are interested in what's happening, what can we learn, then please have a look. One of the things that we do learn from the special issue is that the countries that were able to maintain or had difficulty, where the countries had difficulty was that initially they needed to learn to redirect resources and amend legislation to protect the vulnerable. That was a very, I think, hard-earned lesson, because initially it was very hard. Everything was moving very slow. Do we need to actually invest here? How do we redirect resources such as personal protecting equipment? How do we do it fighting about, I think in the initial stages, I think a few months ago, there was a case where some of the facial masks for health service providers from China was to go to Germany. And then the US government said that because it's produced by 3M, the US has first dibs, and then they actually intersected the whole plane. So those kind of initial redirection had a lot of conflict between countries, and now we're learning that it's easier to do it. So, and at this point, a lot of countries has invested in the health services, thereby we do have a lot of resources. So I think the second wave might seem a bit higher. For example, I think Germany in the first wave had around the top was 4,000 per day. I think yesterday it went up to 16,000 per day. So the second wave seems much more in a worse situation compared to the first wave. But I think with the resources that has been invested and with the learning that has been done, it might not be as as a bad situation than we could think. What else can be done is that at this point, there's definitely a trade-off between health and economic stability. And what's happening, for example, in Victoria, like last week during the weekend, the premier said that he would actually relax some of the restrictions. Some of the restrictions that were put in Victoria, especially in Melbourne, was that you can't move away from your house. There's a 5-kilometer radius, and you can't travel outside that 5-kilometer radius. If you do, you have a $10,000 fine. They relaxed it to 25 kilometers. And how many people are they having today? I think yesterday they had 3 people confirmed. So they are very strict in terms of putting a limitation on how much freedom you have in terms of movement. And thereby there's a lot of economic impact. The jobless rate will be quite high. The income has been quite affected. Thereby there might need to be more stimulus sent out into that region. So we've done this. All of this is done in each of the countries, but I just want to focus one thing, which is about innovation in surveillance and tracing. This is a hot topic because I think this is where a lot of countries would try to revise their laws or like to invest in the future. Now, there's some novel technological approaches that are mentioned in the special issue. And I think 2 of the special countries that I want to pick on is South Korea and Singapore. Now, these 2 countries were noted as the top 2 countries in terms of industrial digitalization by Bloomberg in 2020. So South Korea and Singapore was number 2. The third country was Germany. Fourth was UK, then China, Japan, and then goes to US, France, and Canada and Sweden. Now, South Korea and Singapore to date, they have pretty much contained the virus. You can look at Germany, UK, US, France. They're experiencing a spike of new cases. So what's the difference? Well, I have mentioned that there's a very intrusive technology that has been developed. What is it? In South Korea, around in April, they put a new system. They actually changed the law to be able to implement this system. And this system is that if any health service provider identifies a new patient, then they can access the Korean CDC website database, and they can put in the patient's social security number. And within 10 minutes, that patient's last 2 weeks movement, where that person moved, where that person visited. So it's using GPS tracking, it's using credit card payment, it's using mobile phone information, it's using public transportation information. 2 weeks worth of movement would be automatically printed out and supplied in 10 minutes, right? So contact tracing becomes much easier than before. So previously it took 1 week to do a full tracing. Now it's 10 minutes. Obviously, the problem is it's a breach of private information, isn't it? You have to sacrifice a lot of the private information. Why did it survive? Why did it succeed in South Korea? How could the government do it? In 2015, during the MERS crisis, the Korean government did the opposite. They actually protected private information. They didn't announce it. They didn't share it with the general public. And Korea had one of the worst death rates in the country. So the Korean CDC changed 180 degrees, did this, but while they were doing it in the last 5 years, they did actually try to convince the general public that sharing your private information might actually protect your freedom of movement, will protect your job, will protect the economy. So what they did was a survey that was conducted by the government showed that in 2020, 90.3% of the general public supported the movement of publicizing the private information if it's a patient's movement for the last 2 weeks or even for a month. So you can see that 9 out of 10 people say that, okay, the government should publish these private informations. But surprisingly, 77% of the people that were also interviewed were willing to even give up their own information. And another 10% were willing to give it up if the government had a more rigorous way of collecting and maintaining private information. So around, again, 90% of the general public were saying that if it's a national crisis, then we're willing to give up our private information. And that's crucial. That's crucial if you want to use a surveillance technique, because you need to have trust in the state itself. And that's important, especially for a lot of countries that are trying to use the tracing app. The tracing app, to be successful, needs at least 3/4 of the population. So 75% of the population needs to download it and have it working itself or opened and be effective. They needed to have, as I mentioned, 75% of the population need to have it on their phones. So Singapore is one of the countries that has also embraced the surveillance or tracing technology. They call it the Trace Together app. It's a contact tracing app that came out in around April. They have really strongly publicized the usage of it, but still the uptake is only 45%. So what did they do? They enforced all public venues. So we're talking about hospital, restaurants, schools, libraries, like anywhere you go, if it's within a building and it's not your house, then you have to swipe this Trace Together app in the entrance to even get in. So for students, you need to be able to prove that you are using the app. So they are hoping that the uptake of this app will go up to 90%. So you either force uptake of these apps, or you have to have significant trust so that the people allow the government to do it. And I think that's where the European countries can learn. I know it's a big issue, privacy issue in the East Asian or the Asian culture versus the Western culture is quite different. But that's where I think the governments need to really spend time trying to build up the trust that they will not wrongly use the data. And if any data is to be shared, it will be well disguised so that you can't identify a specific patient. Right, so where do we go from here? I think the technology part is more of the policymaking part. For academics, if you're interested on what's going to happen, then keep an eye on the big data side. There's large amount of public data. There's so much data that's coming out. We need a lot of people who have specialization in big data and know how to implement it in the healthcare atmosphere. So for example, one of the things that currently Francesco, myself, and colleagues are talking about is telehealth in Australia. Telehealth is a way that you can talk to a service provider like a doctor through the phone or through the video chat. We talked to the people in the region. They said that this new technology has been rigorously expanded or rigorously being asked for from the practitioner to use when they are dealing with patients. Unfortunately, they aren't tracking which patients are using which method. So whether it's a telehealth method or whether it's face-to-face. So they have massive amount of data, but they need people to be able to distinguish these kind of different aspects and then be able to analyze it. The other side that I think will be quite interesting is the effectiveness of the stimulus packages. You can see that in the US, depending on which president would actually be elected, whether it's Biden or whether it's Trump, there's discussion about giving everyone $1,000 or something. So whether it's going to be equal support or targeted support, like in Australia, where if you are in the lower earning level, then you get more money. If you earn X amount or more, you get nothing, right? So it's whether it's going to be targeted or not. That's a big debate that I think will happen. The other thing is, as I mentioned, the next innovation, what kind of new innovations can be happening. I will go back to South Korea a bit more because I mentioned that the South Korean contact tracing really worked well. You know what happened after that? The government actually said that because the general public is really trusting how much the government is spending on this infrastructure, the next stimulus package will not be direct injection to your pocket, but we'll spend 17 billion US dollars worth of money in investing in digitalization and green technology. So they're actually investing more in AI and IT. So thereby, I think Korea is already #1 in the digitalization space, but the government is trying to excel in that area. So I think that's where government policy might actually be dictated by some successful policy that has been implemented during this crisis. And that's it. Thank you very much.
Thank you, Duan. Excellent presentation and timing. Now, I have just, you covered a lot of ground. I have just one perhaps a point that we will then also keep for the panel discussion, the open Q&A about the views that, given that you talked about the economic impact, which is now coming more and more on the surface as clearly the issue to deal with, and it will be more and more so going forward. I suppose that one almost natural question that comes to mind is whether the actual differentials that we observe at the moment have anything to do with something that was underlying already in those economy, or whether it can only be explained by COVID. So like Korea is growing, as you indicated. Europe is having a massive downturn. Is that all attributable to COVID, right? So there is, I would say, a more, let's say, general point that perhaps the panel could start reflecting on, that, you know, in all these months that we've been living with COVID, that it's basically the cause of almost everything, right? So now, to put order to that very complex area that is the response to COVID by governments, and not only, also by industry in several countries. Naomi has led a wonderful project together with a few other co-authors that are present here, some in the audience, some in the panel, like Matthias and Marcello, and some that could not be here, that have commented, like Mary Ingwood, Fiorentini, and myself. And I leave the floor to Dr. Naomi Moy to present that contribution that we hope very much can be useful going forward. Thank you, Naomi. The floor is yours.
Hi, thank you, Francesco. Thank you for that wonderful introduction, and for all of you for attending this morning's seminar, and this evening for some of you as well. So the work I'm discussing today is part of a collaboration that stemmed from us wanting to have an understanding of the impact of health and technology interventions on the COVID-19 pandemic. So what I'll briefly be discussing is COVID-19 and how we approached the creation of this standardization to policy and technology responses by the differing governments. So what we did was, oh, that's not working properly. I have not set this up correctly, I apologize. There we go. So what we did was, the COVID-19 pandemic is actually not the first outbreak that the modern world has seen. For example, if you think back to 2009, there was the H1N1 influenza pandemic, and it's also not the only viral outbreak that we're contending with. We still have the Zika virus and other viruses still going around. However, it is one of the most impactful pandemics that we have seen and that we are dealing with. As of the 22nd of October, there were over 41 million confirmed COVID-19 cases, and it was linked to more than 1.1 million deaths worldwide. The response to the COVID-19 pandemic has tend to be what has been used before in previous endemics and pandemics, and it's shaped the government responses to the current crises. So these responses tend to look at the repurposing of drugs, vaccine development, and increased use of PPE and so on. However, many also looked back towards their earlier COVID-19, or not the earlier influenza pandemic responses. For example, New Zealand followed their influenza A pandemic response. Hong Kong started initiating development of their own initial responses. So they're quite quick. But there was a large variation in these pandemic responses. So the responses within country were not always agreed upon. You had some governments being criticized for their response or the speed of their response, and others were being criticized for their strategy used, particularly with in-country criticisms. Then you had different pandemic response objectives across countries. So some pursued elimination strategies, others pursued mitigation, and some didn't even declare their objective. It was more of a knee-jerk response to that something was happening and they needed to do something about it. It might not also be due to this as well. The political environment does play a role, but the responses could also be linked to the high fatality rate we were observing in the beginning, the high R rate, and also possibly due to the asymptotic carriers that you had going around. So the interventions that were being used weren't always as helpful in inducing behavioral response because people didn't think they were infected and therefore not really following them along. So different things had to come in. This has meant it's been quite difficult to understand the impact of the government policy and technology interventions on epidemiological and economic outcomes. So this has led us to want to understand the scale of the pandemic response and whether this response has been and continues to be proportionate to what we're seeing. And overall, we want to provide insight to interventions that are used and their impact on health and non-health related outcomes across countries. So to do this, we wanted to have a look at outcomes. We needed a measure that was informative, and we needed a measure that was going to be able to use in statistical analysis. So we took a look at existing indices and trackers. And what we saw was that in most cases, they just recorded the number of responses and measures over time, but they didn't actually account for the level of strictness or the level of dominance that some of these policies were having in the area. And in other cases, they provided a category for the intervention, but they didn't actually account for the frequency of these interventions occurring, or in this case, also not accounting for the dominance or the effect of individual policies. So we felt that there was a bit of information missing with what we wanted to do and how we could use this information to understand the impact of interventions. So to have a better understanding of the impact, we wanted to provide a taxonomy that standardizes responses and makes them comparable. So comparable across and within countries. What we wanted to do was make it so it differs to existing indices and policy trackers by providing a structure to the measures that account for the frequency and the intensity of the intervention. So we went and had a look at the policies available at the time to create this policy framework. We looked also at the existing sort of epidemiology literature out there, and this led us to categorize 4 categories, 3 of which are the general frameworks of what you see, and then the 4th we ended up separating it out because of the advancement of things. So I'll explain that as we go through. The first one we looked at was policy interventions to contain the spread of the virus. So these are interventions focused on containment, mitigation, elimination, using practices to change individual behavior. These tend to be non-pharmaceutical measures to reduce or stop the spread within a country. These measures are aimed to flatten, reduce the pandemic curve, and are sometimes combined to be more effective. So these measures provide a level of reduced viral spread and can actually be combined to be quite effective. However, they can have severe economic consequences. They can also have consequences on the treatment and prevention as well. So this led us to interventions to reduce the economic impact of containment measures. So these are the fiscal interventions used to reduce the economic impact of the pandemic. We consider these to be the responses that help increase demand and supply side behavior, or help mitigate the effects of containment measures in particular on demand and supply side behavior. These are important to consider because it helps us mitigate the economic impacts of the pandemic overall. And there is examples of this, as we're all well aware now, that it is having a significant impact, but we also know historically that there have been issues. So for example, in the case of swine flu or H1N1, it actually affected the sale of pork in some countries because of this negative association with that. Then you have other areas that are affected, such as tourism, which has been associated obviously with increased spread. And then you have the supply side as well, so not just demand. So an Australian study examined the effects of influenza A and a spread of it through a childcare centre. And what happened was, on average, the staff were losing 13 hours a week because they were caring for sick children or were sick themselves. This burden was then increased as a result on the parents of these young children because they were taking time off to care for their infants. So it affects, the overall effect of a virus can be far ranging, it can be very individualized, it can be on a very macro level as well. So we categorize these interventions used to mitigate or help reduce these impacts under this umbrella. And then our third, obviously it's important to look at your healthcare system. So we wanted to look at the prevention and care measures that were put in place. So these are the interventions that focus on the country's healthcare system, and in particular, resourcing ability to treat active cases. Treatment can be severely impacted in several ways. It could be because the healthcare system doesn't have the appropriate resources at the time. It could be a lack of PPE, a lack of medical staff, which we saw but governments responding to this issue. As Duan mentioned earlier, you saw governments trying to that's inappropriate. They were sort of hoarding resources because they felt they had a requirement to have them. So you have not only resource issues, but then you have the increased expectation of your staff working longer hours. So this can impact the risk they have of getting infected, also impacts the risk you have of lowering your labor force to be able to respond to the advanced medical needs that those who have the virus have. So what we ended up seeing in some cases, where you have a mobilization of resources to increase capacity. This responded to the demand, which generally results in sort of fast tracking of final medical year students. And in some countries, you saw the pop-up of temporary hospitals or the entire reallocation of hospitals to COVID-19 patients only. Now, there are a set of interventions, or we grouped them in the end, that we felt were more important, or not more important, they played more of a central role in government's response to the COVID-19 pandemic. And as health technologies continually evolving, what we ended up doing was creating an umbrella term for health technology interventions. So we consider these to be the innovative technological responses of industries and governments to assist in the testing, tracing, and treatment of individuals. So what we ended up doing was creating a subheading or a subcategory in this sense that looks specifically at the testing, tracing, and treating interventions or policies used within governments. And now these centered around the fact that even from previous pandemics, we've seen advancements in these technologies, and since the beginning of the COVID-19 pandemic, we've seen very swift and rapid involvement of these three areas. Testing can have the greatest influence on epidemiological outcomes. The more you test, the more cases you're going to find, the more effect it's going to have on the interventions you put in. But it is only effective if the testing is viable and cost effective and practical. So in some cases, the tests were very expensive, so they were trying to develop cheaper ones or ones that could give you results a lot quicker. Then you have tracing. So tracing is more effective, as it turns out, and we are seeing this across other countries as well, if your outbreaks are quite small, or if you manage to get a very well-structured tracing system in place. For example, in South Korea, it's a good example for that. But for example, in the UK, it actually took a very long time for them to get a tracing system put up. And even now it's very ineffective. And then we have treating. So treating looks at the advanced medical technologies to provide an opportunity for improved care. This is the example using of repurposed drugs, improved ventilators designs, or in some cases, the use of new technology. So Singapore, in one hospital, they started using robots to go into their intensive care units and actually keep the doctors outside of the room. So the robot was delivering medication. It was had a screen attached to it to deliver the consultation as well. So after all this extra information, what I'm going to show you is the full framework, which we demonstrate how it shifts from our top level into a process where we create a gradient that accounts for the strictness, or not even the strictness in some cases, the dominance of some of the interventions into particular categories. And then we can then try and use these to look at a statistical analysis for future dates. So what we see here is a diagram. The first thing we went through was whether or not these measures were going to be ones that are going to escalate. So as you look at epidemiology factors, are you going to try and keep increasing them, and are you going to de-escalate them? In the case of containment, economic interventions, and prevention and care for particular health outcomes, yes, we figured that was going to be the case. When it came to health technology, we didn't think that was going to be as significant a factor, given that if you have tracing in place, you're not going to want to remove those for the duration of the pandemic, or even remove them in the future. That has its own implications. If you have treating, for example, in the diagram, we have the highest impact you can have is a vaccination. So that's not something you're going to want to de-escalate. So we then moved from this into creating the gradient. So we start from a no response where nothing changes. So once the pandemic hits, nobody's done anything, no one's done anything in these categories. That is now no longer the case. But it then moves up from minimal to medium to significant. And in some of the categories, we move it to very significant. So these are more severe and more stricter. It doesn't happen in all of them. To explain sort of how they work, what we did was, for the containment measures, you have a lot of options to restrict movement. You have border controls, you have school closures and business closures, restrictions on movement, restrictions on gatherings. You can also have non-punishable measures such as social distancing measures, just as a recommendation. You can put out hygiene campaigns. Now, all of these will have an effect to an extent, but ultimately there will always be one that dominates over the others. So we created this sort of criteria that, in the case of containment, the measures became more punishable and more enforceable to enforce behavioral change. It encompasses the existing measures, so it sort of builds up upon itself. And then it's the same as you start to de-escalate as well. For economic interventions, we base these on the level of government involvement in the economy. We started it off sort of from basic general tax relief and tax deferrals all the way to the suspension of a free marketplace into a centralized economy. We didn't really see that happen at all, but it was an option in that you see more involvement in the economy as things became more dire, or as they tried to balance this trade-off. Then in health interventions, we moved from standard PPE, so the very basic treatment provision, all the way through to whether or not your health system resources were fully absorbed back into a central system and was fully dedicated to the pandemic response. So in some nations, you actually saw governments creating a collaboration of sorts with their private sector, so getting those resources back to respond to the pandemic. Now, with testing, tracing, and treating, we treated these slightly differently. Testing looked at the advancements of the tests and how quickly they came about. Tracing, we decided to separate on to the invasiveness of the tracing technology, so whether they were centralized or decentralized. And then for treating, we went from no adjustments straight up to the very significant, which is being vaccination. So all in all, there's a lot of information that we pull into these, but we believe this is a good way of demonstrating the impact of interventions, or hoping to demonstrate the impact of interventions. So I can show you an application. I'll show you three, time allows it. We looked at Italy, we looked at New Zealand, and we looked at the US. Now, Italy is a very interesting case. They were very reactive. The pandemic seemed to sort of come by surprise, as in that it was very advanced before they'd even realized, and instigated a number of measures. So you can see in relation to our containment measures, while they are quite progressive, they happened very rapidly and didn't de-escalate these measures until they were certain they were lowering. Then if you look at the prevention and care, what we ended up seeing in panel B is that whilst we used the case fatality rates with prevention and care not reducing until there was an actual flattening, we also see with hospitalizations that the reduction in prevention and care measures didn't occur until after there was a significant decline. We also had a look at the economic interventions, where we use the market indices for the countries to have a look at how swiftly the economic interventions came into place. And you can see that, around April, when a lot of the lockdowns were occurring, that there was rapid intervention in Italy. Now, we know this isn't the most appropriate economic indicator, but there are significant lags in some of these. However, this is what we have sort of tried to work with. And we do believe this will be more applicable with other economic indicators as they become available. And then finally, you see the testing and tracing. So you have very minimal tracing and testing occurring in Italy at the time. But as we've progressed past the initial wave, these technologies are being invested in. Now, it depends, we'll see with the next set of waves in these countries, whether or not these testing, treating, and tracing technologies will have an impact on the next wave and on what happens there. So we did similar with New Zealand. You could, and interesting enough, New Zealand was one of the few countries that actually declared its objective. So they wanted to follow an elimination strategy from the start. And you can kind of see that in the gradients. So for example, New Zealand very rapidly increased again. And the second blip here is when they had their second wave recently in August, when they had a minor outbreak that they couldn't identify the source from. So they quickly jumped to lockdowns. Again, very similar to Italy. So moving through that. The US, they were a little bit slower in responding, and they did follow some levels. So what we've collected here is actually at the national level. We couldn't include information on the state level as it became a bit too complex, but you could do an analysis with the gradient on the individual states and see how the individual reactions have impacted economic and health related outcomes. So briefly fly through those. So in conclusion, we tried to create a standardization process that provides the ability to observe and influence and increase policy strictness outcomes. We tried to contribute to the policy trackers and indices by combining what we thought was best out of all of them. And in this case is the categorization and the gradient application. We can group them. However, we did feel it was a little bit limited as we can't address the overall impact of the strategy. And then finally, we think it can provide a visual sense whether or not these things have been proportionate, but it's still to be tested statistically. And I apologize for going a little over time, but thank you.
Thank you, Naomi. Excellent presentation. I would now perhaps reflect on let's say the second wave, because I think this framework, has been, slowly being crafted and prepared, and now we're starting seeing here and there some also interesting changes in not only the intensity but the targeting of some of the policies. This is particularly true for European countries, and it's interesting because the policy transfer really has been occurring from the Latin American experiences. This is something we're starting observing now. So this framework has that flexibility to monitor and map these changes. One element that I am observing at the moment that was widely used, for example, in Chile and other Latin American countries, is really to only allow mobility and social activity fundamentally in the daily hours for instead of having measured the really just preclude mobility based on non-essential work or other of the kind. So the curfew measures are now becoming more popular, and not necessarily in the a compliance aspect or dimension of the word, but more from a policy implementation perspective. So thank you, Naomi, once again. Now I have the pleasure to introduce you to the panel discussion, for which we have about 30 minutes. We have an incredible heterogeneous group of speakers that will comment on the presentations, and of course will bring their own experience. Matthias Kistelt, of course I apologize in advance for the pronunciation. Matthias is the CEO of Synergis and has just commenced a new venture. He will say something for sure, or encourage him to do that. He's from Sweden. Dr. Sebastian Rosenberg, who is based at ANU, at the Center for Mental Health, and works also with one of our co-authors. Both Matthias and Sebastian have contributed to the special issue. Craig Dalton was part of this initiative in very initial phases, but unfortunately or fortunately for us in Australia, he has been, Dr. Dalton has been called to actually really help as a first line architect and contributor to our great management of contagion of COVID in Australia. I think initially in New South Wales, but also when the situation worsened in Victoria, he will, and Melbourne. He will talk about that experience if he feels like that would be extremely valued for us. Dr. Bin Lee, who is in the law school, who contributed to the famous legal paper, so no country paper here. There are about 4, as Duan described. This is one with our also Dean of the Health Law School, Tanya Sordin, and Donna McManus from also the school. And finally, our 4th guest editor, Jonathan Trader, professor at Aston University, and also now, I'm not sure, he will probably say the new venture in Norway in greater detail. I don't want to be a spoiler of this exciting news. So this is the panel. I would like to start perhaps with Dr. Craig and Professor Craig Dalton. Any comments that you might have and your view on this pandemic, and also your first-hand experience, Craig, please.
Can you hear me okay?
Yes, Craig. Yeah, perfect.
Okay. Great, thanks. It's been very interesting, and I wish I had been able to contribute more to your efforts, but it's been a busy time. Look, a couple of things. One is that I think many of us in public health have been shocked by what has happened on many levels. I guess I was involved in the 2009 pandemic. Involved in SARS and Ebola response from an Australian perspective. But I think what really shocked us was that some of the biggest organisations with massive public health capacities, such as Public Health England and the Centers for Disease Control in Atlanta, Georgia, where I worked in the 90s. I worked in that institution. It's amazing how they fell over. And I think none of us realised that this amazing public health infrastructure could be subverted so easily, really easily. And, Australia, is basically a very small public health workforce, but the stringency of the controls have worked magnificently, plus being a closed island, at least, that's worked well. And I think what we've seen is that working both in New South Wales and in Melbourne during the peak, it's very clear that despite what a lot of people say about it being simple, you actually have to have an incredibly fast, rapid jumping onto cases. And that's what we do in our small public health units that are spread across New South Wales very rapidly. And, you probably can't cope with more than 10 to 20 cases per day per million population. That's probably about as many as a really good public health unit can track down and can control. Once it gets beyond that, you just can't cope. And even though we've improved over the last couple of months, it will probably take 5 or 10 years to really get to a point where we could handle more than that. We've brought people out of retirement to help, get in the trenches. And so the idea that we can fix contact tracing rapidly, you've seen it's taken quite a while in Victoria, and they still recruit a lot of very junior people. This could take 10 years to get ready, for a country to get ready for this if they haven't got the basic infrastructure. So places like Argentina, who we've been talking to, don't have the basic infrastructure. That they can't fix it within months. It could take 3 or 4 years. So just the other thing about stringency, when I look at some of the stringency measures, such as the Oxford stringency measures, I don't recognise them in reality on the ground. They just don't seem to track what is actually happening on the ground. So I think it's just too hard a job to do it at a distance, and particularly try and do it for the whole world. If you look at the Australian indicators and the American indicators, they don't actually track with what is happening in those countries. Not much to stop there.
Yeah, wonderful. Great comments, Craig. Thank you very much. So I'll go around to the panelists. I think I would like to ask Matthias to jump in. Thanks, Matthias.
Thank you, Francesco, for inviting me and giving me a chance to be part of this. I think when working through this from a Swedish perspective, we realized that I think that it all starts with what perspective do you have on the pandemic? Because I think in general, I think we would see that the discussion is about number of infected versus economy as the equation that we are looking at. And I think that kind of tweaks the view on this. And I would suggest that from a Swedish perspective, and what we're about to start a Nordic discussion about, is that we would consider this from a more of a public health perspective, that on one end, I mean, what really matters is the negative consequence of the disease on one end. I mean, if people die, ICU or things like that. On the other hand, you have the overall function of society, where economy is one part. That's what you have to balance. And I think when you start thinking from that broader perspective, you're going to do different conclusions. And just to trigger the discussion and thinking a little bit, that there has been studies now looking at the region of Stockholm, which had about half of the deaths overall in COVID. And the people dying from COVID or dying from another cause, the people dying from another cause are younger in average than those dying from COVID. So it is a kind of a complex issue where we get caught up in the discussion about the numbers, but we may not have the right perspective of the numbers. And so I think it is important to really discuss what are we trying to accomplish. Mortality in Sweden is really low now. And if you look on the number of people who has been infected in Sweden, it's probably a surplus of 1 million, even during this summer. We see a peak. I mean, it's going up again with infections now. But right now, mortality in ICU is still low. But internationally, the focus is, oh, it's going up in Sweden or in other countries. But I don't know if it really, should we care too much about that if it doesn't lead to mortality and ICU care? Because then we're finding a way to live where people who are not injured get infected and society can still work. So maybe that's another.
Yes, this is, I think you have touched on a point on which we'll come back to that, of course, Matthias, with more from you. But I think I'd like now to follow on this with Jonathan, if he doesn't mind.
Thanks, Francesco, and it's lovely to be here with you all. So just to return to what Francesco was saying, I'm a professor at Aston University in Great Britain, but I'm moving to a chair in Nord University in Norway. And so like Francesco, I have this opportunity to observe the implications of COVID and the response in two very different contexts. And I think that shapes my comments. And here, our paper was done jointly with my colleagues Goril Urshan and Ingunn Schessel, who are both at Nord. And I guess one of the things we haven't touched on is the future implications. And one of those, at least from the Norwegian perspective, is the refocusing of the economy. There's been much talk about the implications of a green economy. And this is certainly the case in Norway, a shift away from hydrocarbons towards a different, or a dependence on a hydrocarbon-based economy towards something else. The second is about the knock-on effects or the opportunity costs of the ways in which we've shaped the delivery of healthcare. So in Britain in particular, we think about this in terms of cancer and cancer rates, but there are a whole series of different ways in which approaches to prevention and immunization have taken playing second fiddle to the response to COVID. And that will have a long-term implication. And indeed, the implications will have an age trajectory and a socioeconomic trajectory or parameters which are different from those affected by COVID. The third thing I wanted to touch on was the importance of blocks. So what we see in the Nordic countries are shifts, and particularly shifts which are related to patterns of policy transfer that have been long made, right? And in some sense within the Nordic countries, the debate over Sweden or not Sweden was shaped, led to responses, particularly around closures of borders, which are very different from traditional patterns of relationships between the Nordic countries. And finally, I wanted to say something about the underlying importance of trust, both trust in the state and trust in science. So one of the things we could consider in relation to the analysis that Naomi has tried to present is ways in which we could cluster patterns of these responses in policy terms, but also in success of the policy in relation to a series of underlying dimensions. One's around clusters of nation states, and a second around forms of trust or lack of trust, both in state and in science. And I think we've seen this in the response to the CDC, to Public Health England and Stakis in Finland, right? The degrees of independence from the state and the degrees of trust in the state and state apparati and insights. Thank you.
Thank you, John. I think this is very interesting. And actually, I think there is perhaps something rather observational. And I'd like to pick your brains, all of you, your brains later on. If possible, it seems also to be that this is the new normality in a sense, in terms also of restrictions and so on to mobility and freedom in general. And at the same time, there is also a decline in interest in the COVID topic as opposed to what it used to be. So that is, or might be, for at least some people which may have a bit of an economic eye and think of social capital and its evolution, that there is an underlying trust factor that drives these elements. So I think that is a very important point, and one of our VheP members, in fact, David Savage, who is not here with us tonight, I believe, wrote an interesting paper, actually a couple of papers on this issue, linking trust with the healthcare systems in a number of settings. So I'll come back to that. Now, I would like to go to Dr. Rosenberg and try to complete the picture and then go to more reflection on the regulatory frameworks and the restrictions with Dr. Lee. But Sebastian, please feel free to comment, given your standpoint that really it's about rapid responses, technology, and so on.
Great, thanks very much, Francesco. I hope you can hear me okay. I'm greetings and apologies from Luis Salvador Carulla, my colleague and professor at the Center for Mental Health Research at the ANU. He can't be here this evening, but he sent his greetings to you all, and thanks for this opportunity, Francesco. So one of the reasons why Luis can't attend here is that he's in some ways replicating the process that we've carried out to date, which included 7 countries across the world. He's replicating that process with the countries of Latin America. So I was interested in you raising that before, Francesco. So what we established was something called the Pandemic Mental Health International Network. And it was a group of people who came together to work rapidly to consider what the implications were for the provision of mental health care at the time of the crisis. Now, I just want to mention, I suppose I've got sort of 3 things that I want to go through very briefly, which covers the 2 articles which are part of the special issue, which I'm very grateful for the opportunity to be part of. So the first list of things is really around the implications for the general system arising from our experience with mental health and with this group of people working on the ground. And so here I take, again, the previous comments that were made by Craig about the extent to which learning actually mirrors people's experiences. Are we actually gathering the information which reflects what is happening with people attempting to manage on the ground? So that was the real gift of the mental health group that we brought together. They were practitioners grappling with beds, grappling with personal safety equipment and training and so on. And we were trying to share that learning in a structured way. So under the general heading of general systems, I suppose, there were issues around definitions that made it very difficult to compare in a structured way what was going on from country to country. And so again, this picks up some of the work that Naomi's was presenting. So I think that's an extremely interesting framework and context to address that issue. There was a lack of predictability around what was happening in a way that people perhaps didn't expect to start off with. People were thinking that there would be a pattern to the way things would work that would be more predictable than it turned out to be. There were real issues around data accuracy, which partly has to do with definitions and partly to do with the way data was collected. So despite that, we were sort of, again, under this general rubric of sort of general appreciation, we attempted to try to build a sort of traffic light approach to demonstrate where people were up to and how they responded and what were the characteristics of that response in a consistent way. And we found overall that internationally, there was a lack of a consistent framework and methodology by which to compare and learn. So that was I guess, under the general rubric. I guess just further from that, and perhaps I'm really poking here particularly at mental health, what we also found really important was this idea of an ecosystem. So you weren't just picking up indicators which related to the usual sorts of things to do with infections and rates and so on. What you were really trying to do was to position your understanding of the implications for COVID on mental health through a broader appreciation of the context of mental health locally. What did it mean for people's housing? What did it mean for their access to medication? What did it mean for their access to other sorts of care? And so that ecosystem approach for their employment, that ecosystem approach was a really important layer that we felt deserved attention. And from that, the last thing I want to mention under this general rubric was this idea about a sort of not just a narrow vision of what epidemiology should be about, but a broader conceptualization of something which Luis calls managerial epidemiology. Doesn't sound overly sexy, maybe, but the idea really was to try to say, we've got a broad range of things that need to be managed for the population when it comes to mental health. And so we need to be thinking at that broad level. So switching then from a general to a mental health specific, there were the sorts of issues which people have raised. There were issues about training, access to equipment, access to services, a range of other things that manifested as the crisis came through, which related to unemployment and increases in domestic violence and so on. And our group was able to compare those issues and understand them. So that was really good. And so overall, I would say that from those two perspectives, a general and a mental health specific, if you like, there were some overall issues which I think were really important and were shared amongst the network. The first one is that it seemed really important and good to have a universal healthcare system that seemed to provide a level of robustness to the approach that was that somebody should tell those interested in socialized medicine in America. The level of integration between primary, secondary and tertiary care and mental health was really important. And perhaps then, not surprisingly, as access to hospital-based care became more and more difficult or impossible, in fact, the robustness of access to community mental health services was a key element which seemed to deliver a level of quality and certainty and access in the COVID period. There was a really interesting tension, which we might come back to as well, about local control versus central control, and the extent to which regions actually manage things themselves. And given the fact that, we put up slides which say Italy or Australia or New Zealand or whatever, but in fact, it varies a lot depending on where you are. The difference in Australia, for example, between being in Melbourne and being in Sydney has been extraordinary over the last 3 months. And I just wanted to mention one other thing, which is really important, which again, we talked about very briefly, telehealth, and people saying, oh, this is a huge change and so on and so on. I would suggest there's two important things to mention here. One is the issue of substitution. So in fact, how innovative is this and what addition is it really making when people aren't attending face-to-face, they're using telehealth services instead, but is it really, how different is it? How new is it? And then the second thing to mention around telehealth is it is operating without standards. So who is being treated, for what, for how long, with what impact is unknown. And at the moment, there will be lots of...
That is, Sebastian, a fantastic note. I know I have to manage, so, at the opera.
A conductor.
I have beautiful instruments here. I'm trying to create that magic sound. So great contribution, and I think that is the point where I would like to bring our lawyer. You talked about clearly standards in relation to that idea. Of course, you can think, of course, about standards and safety in the delivery of care and the modality in which you deliver it, but also in how you basically serve justice. And I believe that part of the picture hasn't really been widely debated. I hope that's a good incipit for your intervention or contribution. Bin, the floor is yours. Yeah, you can contribute. Yeah.
Well, thank you, Francisco. Thank you for inviting me to the panel. I assume I'm the only lawyer in this panel. So, the first point I would like to make is really, the pandemic has not only significantly disrupted the health sector, but also the justice systems, because justice system is part of the human society, which has been heavily impacted by the pandemic. And the second point is that I was really amazed by the presentation by Duan, in the sense that he actually introduced a lot of fantastic technologies like the tracing technology, big data use, and artificial intelligence sometimes. So these technologies are also used for the justice purpose. And during the pandemic, across the world, the court systems have moved the proceedings online, and also in some of the countries, like in China, the big data has been used to formulate a smart court system to alleviate the workload of the judge, so that the backlog actually can be appropriately dealt with. And then for that sense, there would be less delay for the disputes. So this is really interesting because these technologies have been not only used for carrying out health policies, but also to sort of addressing the issue of access to justice during the pandemic.
Thank you for reminding me to unmute. That's very, very important point, Lee, about access to services of all kinds. And you pointed the justice system. I'd like to go back to Craig. He said something before that was quite interesting for me, and then open also to questions from the public. And among the various aspects that you touched upon, you reflected on, of course, the stringency, the fact that it's hard to connect these type of indexes, and that's true, I would say, for almost every index, to what's happening on the ground. In as far as you can, what is happening on the ground? Because, of course, the filter of media in this pandemic has exercised an important weight on our imagination as well, as for those of us who had the misfortune, but also in a sense also the opportunity to live it in person. But we don't see what's happening behind the scenes. So in the healthcare system, in the contact tracing. So what is happening on the ground that is so hard to capture, Craig?
You mean, like, for example, in New South Wales, Australia, or
yes,
or
New
else?
South Wales, Australia,
Yeah.
and from your experience, and feel free to expand, of course.
Sure. Well, I do call my friends at CDC from time to time in America to try and get a catch up on what is actually happening there. So I kind of get an on the ground feel from there where I can. But look, we actually don't know what works well. A lot of people in America cannot believe that Australia has achieved what it has without face masks. Now, I'm very pro face masks, but a lot of people will be certain in America that it was impossible for us to control COVID as we have without face masks, really good scientists. So it just goes to show how difficult it is to understand what works and what doesn't. I think basically you have to have a fairly homogeneous response across the community to decrease contact. So you have to have a high degree of, where they say it's 80 or 90% decrease their contacts. That's got to happen, and you can't have too large a group who think that the pandemic is not happening, as we've seen some places. So you have to have that, and then you have to have a system that can really jump on every case quickly. And as I think Korea, and I would say New South Wales, is meeting this same performance metric, is that you really have to get a result back within 24 hours or less. If you can't do that, you're going to have trouble controlling the pandemic. Then once you get a result, you have to be able to get most of that patient's contacts isolated within 24 to 48 hours. And so you can just go through many countries that are not getting results within 2 or 3 days, sometimes a week, and not getting the contacts into isolation, out of circulation within 2 or 3 days, sometimes a week. And that's just impossible. So that's the sort of health system you need to control it. It's happening well in New South Wales. I understand it's happening much better in Victoria, but they're trying to put in something it's taken 20 years to build in New South Wales over a matter of months. So it's a really, really big challenge. I might just stop there with that.
Okay, thank you.
I might just say one more thing.
Yes.
One more thing. There's probably a false confidence out there that New South Wales and places like this can continue to cope with increased cases, and that what we've seen so far will continue. I think any country that's doing well at any time could fall over, depending on an accident and a spillover into a hard-to-reach group.
Okay, thanks, Craig. Actually, there is a question from Marcello, who's asking, and you have it, probably you can see it in the chat. However, I read it. Your opinion about the strict measure, the very strict measures implemented by Australia, particularly about the closure of borders, internal and external, whether you think this strategy is sustainable until a vaccine is discovered.
I think it probably is. Hopefully it's no longer than 2 or 3 years, or 2 years from now, let's say. If we've got a fairly high level of economic activity in many states, almost back to normal, minus huge sectors like tourism, but some of the internal tourism is replacing that. And of course, overseas education, overseas students. So the economists among you will be able to tell us better whether the having everything minus those sectors is sustainable or not. I'd be interested to hear what you all say.
Yeah, no, that's a very thanks for this. I think I will go to Matthias for complementing that the response to that question, and then Jonathan.
I think this is one of the most important questions. What is the time frame when we expect this to be over? And what if it's the end of 2021? I mean, we're all hoping vaccine is going to be the magic bullet soon. What if it is end of 2021? Because I think this is a key issue for us when we consider the longevity of our measures. And I would say here we're doing rather well to manage for a long period of time. And I think would be interesting to hear the other speakers' perspective of when do they think we can go back to normal, and what are we planning for?
Jonathan?
Yeah, I mean, I think there are a couple of issues. One point indirectly noted by this question is the tensions between individual freedom and the impact of the regulations that we're putting into place. And you can clearly see this differently articulated in different nation states. America at one end of high degrees of individualism, and I would have argued the Nordic states at the other end, where we have much more trust in the state. And in the UK, we can see this in the last week in the debates between central government and Manchester around how much resource will be made available to compensate for increased strictures around lockdown. So that reminds us that it's not only about individual freedom, it's also about the tensions between central and local authority and central and local resources. And that also creates confusion because you get local variation in the regulations, and these are not necessarily clearly coordinated. So again, I think this is partly things that people have touched on. I do think this also has implications for when we think about international comparisons. So just as I'm a big fan of NHS systems, and I think that's really important, both NHS systems and universal access, I think there's a big difference between federal and non-federal nation states in terms of both the opportunity, the speed with which interventions can be put in place, and the response and mitigation that happens. And finally, we're clearly seeing a second wave. We can see the second wave in all of the figures around new cases. But what we're seeing is different rates in terms of hospitalizations and mortality with the second wave. So this may add to an underlying public view of the less of a need to be responding strictly to the strictures, but it may be that there is a change in the way we're handling it, or a change in the ways in which the viral. I'm not a clinical doctor. I'm more on the public health side, but I do think some of these shape both the way we think about international comparisons, but they also shape the ways in which we're going to frame this future. The cancellation of Christmas is part of what the public discourse in the UK is currently.
Yeah, well, in Italy, there is a very good comedian who actually called for anticipation of Christmas, actually, this year. But I like a lot the word that you use, Marcello, sustainable, because obviously there is the economic part of that, but it's also about the social side of it, right? And the connectivity with the rest of the world in the case of the border controls or the rest of Australia, indeed. So I would like actually to go to Duan and Naomi for some reflections on these questions about this measure. Of course, Australia can manage this, and it makes, from a public health perspective, perhaps sense, because indeed it's an island, so that is almost an immediate go-to point. Perhaps some critics in the beginning even pointed fingers indicating that we were not fast enough closing the borders with Italy. And now, of course, there is the other response, like it's been a long time. We can't since we could travel more freely. And now clearly there is the longer term perspective of being in this situation until the vaccine is found. So Duan, any comments?
All the panelists' discussion was very valuable. I like the fact that, although I said that maybe the tracing sort of technology and things can be adapted by other countries, but I do fully acknowledge that there is difference in infrastructure, and the time that will be spent to actually be at a certain level or to implement a very similar policy would be quite different across countries. Like Korea itself, to implement this technology, it took 10 years. So it's not something that you can do in a few months' time, and every place will be quite different. So yeah, it's still a challenge, but it's nice to see that everybody had had a great, I think, view during the discussion today. And yeah, that's it. Right. Thanks.
Yeah. Thank you, Naomi.
I wanted to come back to sort of Jonathan's mention about the recategorization, sort of looking at trust. I think that is a very valid idea. I think that there's definitely cultural influences occurring here that are shaping how governments are responding. So not in just like cultural, how you behave in society, but cultural with your political alignments, as well as it's seeing a lot of impact on the policies, and in some cases is really changing the way how we're approaching public policy. It used to be the standard theory, or you could look at it and go, this is exactly how I'm going to see behavior change, but it's now no longer this case. So I think we have to approach our behavioral research now very differently. I think we can't really rely on just laboratory-based experiments. I think we're going to have to start using a lot more field work and a lot more natural data to get an understanding of the policy implications for future policy recommendations. Anything we look at now and say whether they're effective or not, it doesn't mean they're never going to be effective. It could just mean that the approaches currently taken have been inappropriate for the goal that they want to obtain, or that particular policy wasn't shaped the right way or in an appropriate way that was going to instigate this behavioral change. So I think it's very interesting for us to look at, and we may have to kind of reset how we approach things, particularly in an experimental phase from behavioral economics. So yeah, that was my additional comment.
Thank you. Yeah, maybe I want to go back to some of the aspects that had to do with the impact on justice and the justice system. And literally, I would like to ask Lee to reflect on some issues that are arising, or at least questions that are arising about the legitimacy of some new crimes that have emerged in some countries with a very long history, although volatile history of rights and criminal law and restrictions and persecutions. Like some countries have introduced new forms or new articles in the criminal code, the pandemic crime with jail time and so on. So we all realize, and I like a lot to think of the law, and I'm just a tourist, so forgive me for this, but typically you would imagine that in devising a regulatory tool or a legal framework, you would use the good old barometer of necessity and proportionality, right? So can you comment on this, perhaps?
Yeah, that's really interesting question, Francisco. As you mentioned, after the beginning of the pandemic, almost every jurisdiction in the world has responded with a range of measures, including some of the the measures in relation to law. And I would like to say that justice is at the core of the whole proceedings in the system. By incorporating or devising some of the like the new crimes, for example, into the legislation, I would say that definitely would help address some of the imminent issues arising from the pandemic. And this is from a perspective of the substance of law. And in terms of the procedural aspect, for example, now, a lot of proceedings have moved online, and a lot of court trials actually have taken place virtually. So in terms of that procedural thing, the lawyers as me, see also some of the benefits as well as some challenges in this respect. For example, recently research suggests that, a defendant who is trialed online is more likely to be convicted than the defendant tried in the face-to-face traditional way. So, these kind of things reminds us that while we are taking up some of the technology into our system to assist with dealing with some of the issues arising from the pandemic, on the other hand, however, we need to ensure that the rights of the defendant, for example, also are at the, within the parameter of the justice system.
Very good,
and
thank you.
Yeah. I just stop here, yeah.
Okay, very good, thank you. We'll have more opportunities. Oh yeah, Jonathan wants to intervene, and then I have a question coming for Sebastian.
I think this issue about to what extent law supports public health interventions has been argued about in the discipline. So to what extent can you lock up someone who's got antibiotic resistance tuberculosis, for instance, because they're a potential public threat? Or the extent to how do you respond to someone who's HIV positive, who's spitting in public, or someone who's COVID positive spitting in public? And these are cases that have happened in the UK recently. So we can't lock up people who have antibiotic resistant TB. We offer them treatment, but we can't require them to stay effectively in quarantine for the months that are needed for us to be able to treat them effectively. And we can use assault as the response to someone who's spitting, who's infected. So the extent to which we need specific laws related to pandemic, or the extent to which we can articulate existing legislation or existing law to respond to issues that emerge in pandemic, is something that we've seen in public health, and different jurisdictions are responding in different ways, I would suggest.
Yeah, very true. You're calling for an action you refer to, for example, speeding or whatever, the crimes have been introduced also for not wearing masks, right? And of course, there are different fines, and so we're in a very fine and delicate line. But anyway, the question is open. Sebastian, to conclude, because we have to wrap up, really, 1 or 2 minutes to reflect on the big, let's say, elephant in the room. There is discussions everywhere about the impact of COVID and the responses to COVID on mental health. Clearly, it's an area where there is or there has been moral hazard. And I would like your comments on it.
Okay, and I've got 2 minutes. I'll be very quick. Look, this is my overall view. Australia is a rich country and was well placed to respond to pandemics and to health problems altogether. And it's generally regarded as one of the best performing health systems in the world. In making that assessment, there is no inclusion of mental health. And so I would suggest to you that, in fact, in mental health, our system is very poorly set up. And so you very briefly, Francesco, said, how do we build back to normal? I don't want normal. I think we actually have to and in fact, COVID presses on the one spot in our mental health system, which is weakest, which, as I mentioned before, is in community mental health services. In a very broad brush, you have the federal government that pays for primary care and the state government that pays for acute care. And there's almost nothing in between. And yet that is precisely where COVID is making people need care, seek care. And so our system is very poorly set up to respond. And I have to say that overall, even in places like Italy, and in difficult places in Italy, like Friuli, where there were cases and it was difficult and so on, even then their capacity to flex and respond was based, had more solid basis in mental health because of the community connections that they had. In America, where things were much more fractured, that kind of community response was much more difficult to maintain. In the United Kingdom, with links between mental health and housing in some places, again, community links are much more robust. So I would say overall, that is one of the key learnings for me, which is that mental health was a poorly set up system in Australia, despite being in a rich country, and we need to do much more than build back to normal.
Thank you very much. Look, we are well over time, so thank you for the extra effort to everybody. I would like to really thank Duan for his contribution. Stay tuned, of course, because we're having more webinars coming in the next few weeks. The next one, it's going to be on the 6th of November, if I'm correct. Ayman, please correct me if I'm wrong, of course. We will focus then on the case studies and focus on European countries mostly, but also North America and others. So also thank you to the panelists, Matthias, Sebastian, Bean, Jonathan, and Craig. Very much appreciated your contribution today. So I will now say goodbye to my friends in Europe and wherever you are, and I'll give the floor back to Ayman and Siegfried to conclude.
I would also like to thank again our presenters and the panel members. Thank you so much for this interesting discussion and conversation. We will have, yes, our next webinar with the VheP group on the 6th of November, and we will have our third and final one on the 20th of November. So stay tuned. We will, of course, invite you, and we will share with you the recordings after. Thank you so much. Have a great weekend.
Thank you. Thank you for setting the scene, and see you soon. All the best. Have a nice evening.
Thank you.
Thanks.
Bye, everyone.